Welcome, everyone. Thank you for joining me for another episode of the Eternal Vitality Podcast. This is episode number 24, and we're going to talk about Achilles tendon injuries today. Now, I've been talking a lot about sports medicine injuries recently. That is my specialty after all. But many of these are affecting our quality of life. And as we get older, they unfortunately have a tendency to occur and hinder our ability to exercise, our ability to just have a good quality of life. So understanding why these happen, how to prevent these, or if you happen to suffer from one of these, how to get back as close to 100% is part of my goal. As a non-surgical sports medicine physician, I try to explain injuries to patients in the best way that I know how and give them different options, both surgical and non-surgical. Part of what I'm doing here is an extension of that. It's hard to speak with a patient for a half hour, 45 minutes, an hour for most physicians. I have a unique practice where I spend an hour to an hour and a half with each patient. But again, that is very rare. So if a physician says, hey, you just tore your Achilles, what are your options? I want you to be able to say, okay, there's a good podcast. In a half hour, you will know everything you need to know. And it will give you a much, much better information than you randomly scouring the internet or talking to a physician for about 3 minutes that says, hey, this is what you need, and not really giving you time or energy for questions. We've seen a significant rise of Achilles tears over the past 20 to 30 years, not only in the United States, not only in different professional sports, but also globally. So this isn't a turf situation, as many people like to say in American football, but that may play a role, but there are other factors that are playing a role, and that's what we're going to discuss in a little bit. This is a, unfortunately, very common injury, or not very common, but it affects about 1 million athletes a year. It is the most common tendon rupture in the lower extremity. It is the most commonly torn in the 3rd to 5th decade of life. You can have it in your early 20s. We do see that in professional sports, but usually it's 30s, 40s, and 50s. Now, acute ruptures present with sudden pain. Some people describe it as a snapping or a popping. I've had patients look back like they were kicked or even shot. The very dramatic. In basketball, oftentimes you can see the tendon recoil as it's tearing if they slow down the image fast enough. Rarely can you see it in any other way because they're not videotaping you. But we've seen that multiple times, and it's pretty gruesome. This tendon has a significant role in our lower extremity. It basically is responsible for picking up the foot. So without the Achilles tendon, you can't pick up your toes and you will eventually trip and fall. So people who have a torn Achilles or really beat up Achilles and it's not firing properly, they basically have to kind of walk almost with an angle because they don't have the ability to pick up those toes. Now, this injury causes significant pain and disability. This is a year-long journey. This is nothing to sneeze at. A very, very big deal. Now, it is most commonly seen in soccer, racket sports, and basketball. And it actually is misdiagnosed as an ankle sprain in about 20 to 25% of the case, which is pretty crazy. 10% of people feel what we call prodromal symptoms before the actual injury, telling you that, hey, you have something going on in there. I need you to take this seriously. Some people, the majority of people, unfortunately, it doesn't happen, and they go from being fine to tearing their Achilles, and now they're in a boot, they're in the operating room, they're non-functional for 6 to 9 months, sometimes up to 12 months. Now, what are the risk factors? There's actually a lot of risk factors here. In my opinion, I've only seen this in men, although there's, it can happen in women. It's just not as common. In terms of medications and impact, corticosteroids have a significant role, and they do weaken this tendon significantly. You're also talking about any of the fluoroquinolone antibiotics, which are your Cipros or Levaquins. Though that class of drugs have a tendency to increase the rupture rate for whatever reason. And if you take that along with a cortisone, say, or a oral steroid, say you're treating a pulmonary infection, a bad pneumonia, or something like that, you can take both of those. Those are a common combo, but you are at significant risk of rupture. So be careful of that if you are taking that or if you are prescribing that. Now, oral bisphosphonates also play a role. Overexertion, poor conditioning before an exercise, a previous Achilles injury obviously makes sense. Diabetes is actually a big one. It has to do with blood flow and organization of the tissue. Hyperparathyroidism, which is too much thyroid. End-stage renal disease has a significant correlation here. Lupus, gout, rheumatoid arthritis, and there are some genetic risk factors. Now, epidemiology-wise, there's about 40 patients per 100,000 that tear their Achilles annually. So it's not super common, but it's definitely not rare. Now, there's been a significant rise in the past decade, really 3 decades. And the most common consistent thing that I've seen is because adults are playing sports much later in their life, 30s, 40s, 50s. And that's a significant risk factor. 75% of the tears occur between the 3rd and 4th decade of life. The most common sport is runners, 7 to 18% of the total tears. Dancers are about 9%, gymnasts about 5%, and the rest of the sports are with 1 or 2%. As I mentioned earlier, this does affect 1 million athletes per year, so this is not a small number. And in my opinion, it is growing. Now, we're going to talk even more deeply in a little bit about how this applies to the NFL, but I want to talk about what I call the pathophysiology, or why this happens. Now, the Achilles tendon is the strongest tendon in the body. It actually twists. This is very unique. So on the left side, on the left leg, it twists clockwise. On the right side, it twists counterclockwise. Now, rupture occurs when the tendon is exposed to excessive tensile loads. Think of it as a rope attached to a dock. The tendon would be the rope. The dock would be the bone. You're pulling on that rope, and it starts to fray, and then it just fully tears off of the dock, and that bone, or the dock, is just sitting there, and there's no more tendon, or it's partially torn, and you only have 50% of a rope. That's essentially what happens. Now, there are structural factors that play a role here. The Achilles tendon is mainly comprised of type 1 collagen fibers, about 90%. These basically form what we call fascicles. Now, these are dense and run parallel. As people age, the fibers become less organized and they are prone to degeneration, basically fraying of that rope. Certain diseases can also compromise that structural integrity of that rope, as I mentioned earlier. Diabetes is a big one. We have hyperparathyroidism, some lupus, and think of all of the diseases that we get cortisone for. We get an oral steroid burst. Oh, I have another infection. I'm getting another oral burst. Oh, I have back pain. I need another round of oral steroids. Every time you do that, you're increasing your risk of other injuries, including the Achilles tendon. Now, there are also biomechanical factors that play a role here, because there's a correlation with stiffness and potential rupture of Achilles. High foot arches are actually a protective mechanism and have lower rate of Achilles tear, which in my head means lower arches have a higher rate. So if you had a choice, you'd rather have a higher arch than a lower arch. So how would you check? You put your foot flat on the floor and you stick your finger underneath your arch of your foot. If you can stick your whole finger in there and you still have room, you have a high arch. If you can't put your hand underneath there at all, then, or you're barely squeezing it in there, you have a low arch. And that usually causes a lot of problems in general. Now, when the tendon is exposed to chronic stress and repeated microtrauma, combined with the fact that it has a very poor blood supply in a very specific section that we call the watershed area, this leads to degeneration of the fibers. Remember, The body struggles to heal areas that do not get good blood flow. That's tendons and ligaments. Think of the ACL, think of the Achilles, think of the rotator cuff. These are areas of poor blood supply, whereas a muscle and a bone have fantastic blood supply. If you injure those, you strain those, you fracture something, they will heal well more often than not because the body's delivering nutrients all the time. But if you have an area that does not get good nutrient delivery, that area is going to struggle to heal. The body's going to put scar tissue. It's not going to organize what we call the fascicles of the collagen the same way as if it had good blood supply. And as a result, it does not heal or heal well. And that's what we see here. Now, the Achilles tendon, as I mentioned earlier, is really strong. It holds about 10 times the body weight during explosive movements. That's insane. But unfortunately, it is at risk for rupturing. Now, there is an area about 2 to 6 centimeters above the heel from the insertion that has a really poor blood supply, the watershed area. It's actually the narrowest part of the tendon, which isn't surprising. And that's where most ruptures occur, more often than not. I'd say at least 75%, if not higher, are there. You can have what we call insertional, you can have closer towards the calf, but it is quite rare. It's almost always in that area. As I like to say, common things are common. Studies have found that there is a reduced capillary oxygenation and microperfusion at about 5 centimeters above the calcaneal insertion, the tubercle insertion, compared to about, say, 1 centimeter above the insertion. So it's that 5 centimeter, that 3, 4, 5 centimeter area that really struggles. So if you want to get an idea, and we'll talk about this in a sec, how bad yours is, you can lay down, you can kind of put your foot, kind of plantar flex it, and then put an ultrasound probe on there. And within 30 seconds, we can tell you how that tendon looks. Is it beat up? Is it frayed? Is it partially torn? Is there any tendon there at all? Does it look fantastic? Is there calcifications in there? Very, very quick, easy, and can save you a lot of headaches. Because once it's torn, it's torn. You cannot go back. You cannot, go back and, past go. Unfortunately, that does not exist. You have a brand new journey after you tear it. But if you can prevent it from tearing, different story altogether. Now, what is the most common cause of this? You're going to have sudden forced plantar flexion of the foot. You can have direct trauma. And you can also have what we call long-standing tendinopathy or intratendinous changes, that degenerative changes that fray that rope, and eventually the rope can't handle the stress you're asking it to handle, and it fully ruptures. Now, after the rupture, this is interesting, the type 1 collagen fibers, which are dominant, 90%, are replaced by weaker type 3 fibers. This tendon is never the same after rupture, regardless if you do surgery or not. It is not the same. The body doesn't treat it the same. It doesn't have the ability to rewind and be able to handle that same load over again. Now, how is this diagnosed? This is very painful. This is very swollen. You can't walk. It's awful. A calf strain is awful. These are a different level. These are very painful. We do something called a Thompson test. So basically, have the person lay down, you squeeze their calf. Squeezing the calf is going to cause the Achilles tendon, which is an extension of the calf, to fire. That's going to cause the foot to pull up. If the foot doesn't pull up, that usually means that the tendon is not attached anymore. So you can squeeze that calf all day long, and it's not going to pick up those toes because it's not attached. That test is so sensitive that it's 96 to 100% positive. If it's positive, you tore it. No ifs, ands, or buts. You can get an ultrasound, you can get an MRI, but it's a formality at that point. It's torn. Now, there have been many professional athletes over the years that have been plagued by this unfortunate injury. These include the legendary Kobe Bryant, Dominique Wilkins, Kevin Durant, DeMarcus Cousins, among many, many other NBA players. Usain Bolt just tore his about a month ago or so while playing soccer. Dwayne "The Rock" Johnson did it about 20 years ago or so. I think it was on a movie set. The past season in the NFL, we saw Aaron Rodgers, we saw Kirk Cousins, we saw Cam Akers tear his for the second time, and J.K. Dobbins. Dan Marino did his about 35 years ago. Not a common injury in quarterbacks up until last year. There was really only 3 or 4 cases that we knew of. So interesting, and I'm going to talk about that in a second. David Beckham tore his during the World Cup. I don't remember which year it was, but that was a big deal. Not super common in soccer, but it can happen, and it has happened. Now, there's been a significant rise, and I'm writing a paper on this that I'm going to put on the injuryexperts.com website that shows how and why, possibly why, there's been a significant rise in Achilles tendon tear rates, specifically in the NFL. Now, if we step back and say, is this happening only in America? Is this happening only in sports? Well, there was a study recently released, I think it was from 2022, from Finland, that showed the general population from the 1990s had a Achilles tendon tear rate of 2.1 per 100 person years. But in 2019, it was 21.5. That's a 10-fold increase in regular people over the past 30 years. So it's not just professional athletes. It's not just Americans. This is happening all over the world. And I think there's a correlation with multiple things. I think medications play a role. I think increased age of activities play a role. I think increased age overall plays a role, because if you're living longer, you're going to be more active and you have explosive sports. That is going to correlate. Now, let's kind of hone in on the NFL now. From 1980 to 2001, there were about 4 tendon ruptures a year. 4. From 97 to 02, there was closer to 5. So really, the 80s was about 4. The mid-90s was about 5. And then there was a study by Hewitt, I'll put the link in the description below, that in the 2011 NFL lockout, due to issues with them not being able to practice, they had 12 ruptures that season. Between 2009 and 2014, a study showed that there was a significant increase in tendon ruptures, between 13 and 16 a year. I just told you there was 4 to 5 from the 80s and 90s. Massive increase to 13 to 6. That's 4-fold, almost 5-fold, depending on what year you're talking about. Now, a study by Krill showed that between 2010 and 11 and 2016 and 17, there were a total of 109 Achilles ruptures in the NFL. That's an average of 15.5 ruptures per year. Now, this is hard to find. There is not good concrete database. I have one that I'm building, but you can't just say, hey, how many people ruptured their Achilles in the NFL in 2017? You won't find anything that has a concrete list that I'm aware of. I have one for the past couple of years, but it's taken a lot of digging, and sometimes I feel it's still not complete. Now, the rate of Achilles tendon ruptures has doubled from 0.341 injuries per 10,000 athlete exposures in 2009 to 7.31 in 2016. 0.341 to 7.31. That's a huge spike. Now, COVID played a significant role in this as well. There was a market increase in 2020, 2021. Remember, a lot of people couldn't get access to facilities, couldn't get access to training with individuals. There may have been additional factors, medication related, but there was also a big spike there. And then over the past 3 seasons, there's been on average 17 Achilles tears per year. Now, last year, 2023, from what I can tell, had the largest single season ever tear rate in the NFL. Ever. 22 players I counted. That's insane. And when you consider that one of the players was given a massive amount of money and was expected to turn around the New York Jets franchise, that is Aaron Rodgers, and he only lasted 4 plays. Kirk Cousins, who was an Iron Man and didn't miss really one game, I think, in like 8 years, tore his halfway through the season. Cam Akers, a running back, tore his 2 years ago. He tore his other side this past season. Marlon Mack, another running back, tore his for a second time. We don't know if it's the same side or opposite side. That's just the notable offensive players. Running backs, now quarterbacks, and usually defensive players. Namely defensive tackles or the defensive ends, because they're constantly exploding off the line. And as you can imagine, that tendon is going to take a beating. There has been a 300 to 500% increase over the past 30 years. That is unbelievably alarming. Now, what is the return to play in the NFL after an Achilles tear right now? About 61.3%. 39%. Almost 4 out of 10 never return to the field. And unfortunately, I know several of them. This is a very tough injury to come back from. And if you do, you're never the same. Never the same. This is a tendon that needs to be put under tension. What happens if you return too quickly and you push that tendon? It will loosen and you lose that tension. A very famous defensive end that I know, that I will not say, this is what happened to him. As he was rehabbing, he pushed it, trying to get back, lost the tension, ended up having a little bit of an infection, had to have a second reconstruction surgery, and never returned. Unfortunately, it happens. This could have was a top 20, 30 player. That's how bad of a deal this can happen. This is not a little injury to joke about. Despite the initial thoughts of the researchers of the papers I looked at, risk factors like age, number of prior seasons, position type, and draft round status did not significantly affect the return to play. For those that were able to return, the significant performance dip was predominantly in the first season. Although I have some disagreements with that statement because I've noticed a significant decline specifically in running backs after this injury. Now, the study, there's a couple studies, but one main study discussed what were the most likely impacts in order of power. Now, the most powerful one, the one that was the most effective, the one that affected this tendon injury the most, was the demographic factors that came out. Age, activity level, height, body mass, and BMI played significant roles. Think about what this tendon is doing. You put your foot in the ground and you need to push off explosively. If you have a body mass index of 25, you're an elite athlete. Great. What if you add 30, 40, 50, 70, 100 pounds? Now you're giving more stress to that tendon. But it's not just doing it once. You're doing it 20, 30, 40, 50, 60, 70 plays a week. Not only that, you're usually trying to run through someone. So there's additional force being placed. There's a lot of moving parts, but unfortunately it makes sense. The absence of sufficient preparatory training, such as heavy eccentrics, that's key here. This has likely increased due to the new collective bargaining agreement between the NFL and the NFLPA, which restricts team access to players in the offseason. I think it's silly. And that's why almost all of them have their own personal teams that they hang out with, that they work with, trainers, physical therapists. Many of them are here down in South Florida. I know many of them that all train together. And these are high-level therapists that stress these guys appropriately because this is what they need throughout the offseason. You can't just turn it on. That tendon is not going to be happy. That's why we see a lot of these soft tissue injuries in the preseason and over the first 6 weeks of the season. Now, I feel like this needs to be said. The surface area, i.e. turf, with the newer generation of rubberized turf versus graft does play a role. We may not be able to prove it, but it plays a role. Shoe, rigid ankle taping, and bracing all also play a role. Now, why I'm going to talk about this for just a second. Why do I feel that the new turf plays a role? When you put your cleat into grass and you push off, what happens? The energy disperses through the cleat and will cut the grass. What happens when you do the same thing in a rubberized turf field? That cleat's not going anywhere. So what happens? That energy is now dispersed inside of the body. You have to pick up the foot to move. You're not cutting that turf. That's the purpose of it. They want it to look pretty and stay strong all the time. But unfortunately, the tendon needs that energy to be dispersed, not to be recoiled. And in my opinion, that's why, even though it may not be a direct correlation, hey, he's playing on turf today, he tore it today. And in my opinion, there is a chronic accumulation. And that's why a lot of these guys hate playing on turf. It looks great. It always looks great. But unfortunately, it's hard on their bodies. Remember, there's concrete under it. And it doesn't disperse energy like regular grass does. Okay. Finally, the fourth possibility, the use of anabolic and corticosteroids. Now, there's not a whole lot of anabolics in NFL anymore, in my opinion. 20, 30 years ago, maybe. It's much harder to cheat now. Corticosteroids, unfortunately, are prevalent. These guys love taking their Toradols, their Tramadols, their ibuprofens, any of the anti-inflammatories. And unfortunately, that does play a role. These have issues and can have a correlation with weakening tissue and possibly weakening enough to cause rupture. Now, I've seen a study that talked about compensation from opposite leg lower extremity injuries. We saw that with J.K. Dobbins. We saw that with Cam Akers. So, yes, I believe there is some truth to this. There's some method to this madness. The study I'm referring to is by a team called Krill, K-R-I-L-L-E-R, and the foot injuries to the contralateral limb contributed to the subsequent rupture of the Achilles. Remember, if this side is weak and you're compensating with this side has to try harder, and now you're at higher risk for rupture there. Now, what are the different treatment options? Okay, so we're going to finish strong. There's still a debate about what is the best treatment option, surgical versus non-surgical. Now, if you're a regular Joe, this is a regular debate. This is a legitimate debate. If you are a professional athlete or a very high-level athlete, unfortunately, you probably need to get reconstruction. Conservative management shows that there is a slight higher risk of re-tear in the non-surgical or the conservative management people. But it's only about 1.6%. Not really that big of a deal. Now, you're probably thinking, well, if I don't do anything, how does this reform? I don't think it really reforms. It kind of builds a mishmash, hodgepodge of a new tendon. but it's not those type 1 beautiful collagen fibers. It's type 3. They're not pretty in parallel. They're all chaotic. It is nowhere near as strong, but it usually does the job unless you need it to be really explosive over and over and over again. Then it's a different story. Now, there are some issues with operative that you have to consider. Surgery is not always perfect, usually far from it. Now, you can have wound dehiscence, which basically means that it's opened. You can have infection. Unfortunately, I've seen it. This is a very poor blood supply, as you remember. Blood supply leads to infections because there's not blood in there to remove the infection, to kill the infection. You can have overstretching of the tendon, which I mentioned earlier. If you don't repair the tendon, then you can't overstretch it. But if you just put a new tendon in there, you put a heel lift in each week or every other week, or remove a little bit of the heel lift in the boot, and you decide to push it too quickly, and you lose some of that tensile strength, that's it. You need to go back to the operating room and do it again. And finally, you can get a DVT. If you're laid up, you're at increased risk for blood clot, usually in the calf, which can travel to the lungs. Okay, let's talk about the non-operative, aka conservative options. Initially, you're going to have pain. So you need rest, elevation, ice, pain control, and then you can talk about functional bracing. Physical therapy is vital, whether you do treatment, surgery or not. And finally, we can talk about regenerative medicine. I'm going to go into that in a minute. And there's a lot of modalities that you can use. Something called PEMF. You can use a hyperbaric chamber, which is becoming more popular. Red light therapy, as well as peptides, which I will refer you to one of my original podcast episodes, something called BPC 157, thymosin beta 4, are both fantastic for healing. Now, let's talk a little bit about the different regenerative medicine options. As you may or may not know, that is my personal specialty. This is all I do. I do not give cortisone. I do not do surgeries. I specialize in regenerative medicine, aka stem cells. So let's talk about what you can and can't do. There is data to support that PRP, which is platelet-rich plasma taken from the blood, has better isokinetic muscle after injection. The people who get PRP have higher functional scores than people who didn't. They had better improved ankle range of motion compared to the people that did not get PRP. And PRP on a potency scale is about 3 out of 10 for the good stuff. So it's not super potent, but it works. It's pretty strong, but compared to stem cells, not super strong. But as you can see, it works. And a lot of times we mix them together. Now, the other data for this specific one, without getting deep here, is something called bone marrow aspirate concentrate, or BMAC. That's basically take bone marrow out of your hip. If you're making it concentrate, you're going to spin it down, and then you're going to inject it back into the Achilles, into the calf, into the surrounding tissues where it's attaching directly into the tendon so that you can reinforce it. Now, this has shown to improve clinical outcome and reduces foot pain and ankle pain without the risk of serious side effects, as per studies. Now, you can take this a step further, and there's other different products available in different parts of the world that further can enhance this. I've seen some fantastic results personally with different types of orthobiologics. This stuff works. Unfortunately, not covered by insurance, so it does get a little pricey, but it definitely allows people to get back to much better quality of life, especially if you don't want surgery or you're not a surgical candidate. Let's talk about the different types of surgery, and then we will call it quits. Now, the old school way to do this is what we call an open repair, but that's not very common anymore. That's an incision. They go in, they kind of debride it, and then repair it. Now, the next version was called a mini open, and this is where they make a small incision, much smaller than the open. They basically debride it in something called a Krakow fashion, and then they put anchors into the heel and kind of tack it back down. The newest kid on the block, which isn't really new, becoming more popular. This is what Aaron Rodgers had. This is what Cam Akers had per reports, is something called the speed bridge. This specifically was designed by a company called Arthrex, and it is called the PARS system, P-A-R-S. And I'll show a picture of that. But in general, there are some complications specifically with this surgery. There's about an 18% chance or rate of a sural nerve injury, which is a nerve right by there. And the calf size, from what I've experienced, is never the same as pre-injury or as the other side unless you had tiny calves to begin with. You can almost always see if someone had an Achilles reconstruction when you look at them from behind, because one calf is way smaller than the other, even if you can't see the scar anymore. Now, the rehab process is long and grueling. 9 to 12 months is common. This is not a quick turnaround, unfortunately. This is very debilitating, and it takes over your life. But, and that's why I was preaching earlier, I'd rather be proactive than reactive. I hope you found this helpful. You can see I mixed this one with a little bit more injury content, specifically for the NFL, as well as a not super popular, but significant injury. I would love to hear your thoughts. Do me a favor and check out some of my other podcast episodes. If you're interested in NFL injury content, I have another company called The Injury Experts, experts with a Z, that you can check out at theinjuryexperts.com. That has all the NFL player injury histories, has a deep dive into Achilles tears and return rates and a bunch of other stuff that you may find interesting. Stay tuned for next week's episode. If you like this type of content, do me a favor, smash the like, thumbs up button, and if you would be so kind to leave a review on one of the reviewing platforms. Thank you very much. We'll see you next week.